Thank you for joining me for this week's lecture. We're going to talk about carotid ultrasound today and go over some of the details that may help you in your carotid scanning. Our objectives for today are to list the essential components of a carotid duplex exam, identify the normal waveform characteristics of the carotid vessels, including the CCA, ICA, and ECA, define the common diagnostic criteria used to evaluate the carotid vessels, and describe common pathology observed during a carotid duplex ultrasound exam. So now we'll take a look at the purpose or the indications for a carotid scan. First of all, one of the purposes is to identify stroke risk by looking at the amount of plaque and stenotic change that a patient may have in their carotid arteries. Secondly, it can be utilized to plan treatment. If they have known plaque and they are going to have treatment such as an endarterectomy, this can help you determine locations of stenosis and the type of documentation of classifications of stenosis in order for them to plan their treatments around. It will also be utilized to evaluate disease progression or track changes with pathology in the carotids, and finally to assess the carotid vessels for other pathology besides the typical plaques and stenotic changes that we're used to looking for. Some of the indications that may cause a physician to send us a patient for a carotid exam would be a neck bruit, or the sound of whistling in the neck when they're oscillating those carotid arteries. Patients that have transient ischemic attacks or TIAs may be sent to us to evaluate for changes, as well as a patient with a history of stroke. Some people that are at higher risk because of things such as diabetes, smoking, other issues that cause vascular damage may be sent to us. And finally, people that are following up on a post-endarterectomy procedure are all some of the indications of why we may see a patient. So we talked about some of the indications for a carotid exam. Now we're going to talk about some of the causes of those, some of those symptoms that may get a patient sent to us. First of all, one of our most common is going to be plaque emboli. So we know that plaque can develop in our arteries due to a number of different issues. First of all, you could have plaque buildup as fibrotic change or scar tissue from trauma. You can have plaque buildup because you have elevated lipids in your system or hyperlipidemia. You can also get plaque developed when you have some disruption of the intimal lining of your vessels. So things like smoking, having high blood sugars, things like that will cause roughening up, irritation of those vessels, which can either then fibrose or scar, thickening the vessel wall, or it can cause a roughness on which lipids and other things can attach, creating a plaque. Now, when these plaques get large enough, they often cause a reduction of flow. So the reduction of flow, we know that our brain is a highly vascular area and it's going to have a very low resistance to blood flow. Our carotids are feeding our brains as well as our facial and thyroid, our facial muscles and thyroid, and a number of other items. So when we have a reduction in flow to any of those areas, we're going to see changes in our function of brain, thyroid, whatever it is that's being affected by the disruption. We also can have an arterial thrombosis or a blood clot developing in the artery. Now, both a thrombosis and a plaque have the possibility or the potential to break free, get lodged into a cranial vessel, and cause a stroke to our patients. So any of these things can lead to cerebrovascular symptoms, and therefore by looking at the carotid arteries, we can identify where some of these things could be coming from and what the patient's risk factors are for experiencing. Okay, so we just spoke about how stroke and TIA were indications for a carotid duplex exam. Now, a stroke is caused by a lack of blood flow to some tissues in the brain. So this can either be from an embolus breaking free, lodging itself in an artery in the brain, or it could be from a rupture of a brain causing it to bleed out so that the blood was never to reach the tissue it was intended for. Same thing with an embolus. If it gets lodged in that brain, or lodged in the vessel, then that particular area of brain will not be able to get perfusion from the blood flow like it intended. So either of those two things will lead to necrotic changes in the brain tissue. Those necrotic changes can result in fixed or permanent deficits, such as changes to motor, changes to verbal skills, changes to drooping of one side of the face, and in a multitude of effects. But the important thing about these stroke effects is that they are permanent. Now, oftentimes leading up to a stroke, a patient will experience TIA, or transient ischemic attacks. And the TIA really has those similar stroke-like symptoms, except they're intermittent. So they'll have those negative changes, but those changes will typically resolve in about 24 hours. And what's interesting about TIA is usually the symptoms are on the opposite side of the pathology. So if it was your right internal carotid artery that was having, let's say, significant stenosis, it might decrease the amount of blood flows to the tissues as a whole. If it was on the right side, you typically notice left-hand deficits. So that's going to be a really good indicator of TIA. And of course, like I said, it's going to resolve in 24 hours. Then there's an example, or there's another pathology called RIND. So RIND is reversible ischemic neurologic deficit, and it kind of falls in between the stroke and the TIA. In this, you have those same type of stroke symptoms. They last longer than the TIA's 24 hours. However, they resolve themselves within about 48 hours typically. Now, TIA and RIND are both indicators that a stroke may be coming. There's something in there causing the reduction in blood flow, which is leading to these symptoms. Now, some of the symptoms that we talked about from those stroke symptoms, or the TIAs even in the temporary example, are going to be things such as focal weakness or paralysis of one side of the body, again, typically opposite the side of the pathology. Another could be numbness or paresthesia, involving some sort of combination of face, arm, legs, all on one particular side, contralateral to the affected side of the vessel. And the people may have difficulty speaking, or dysphagia, which would be difficulty speaking, or aphasia, where they cannot speak at all. And then finally, another indicator would be amaurosis fugax. In this case, it's a TIA, transient ischemic event, and it causes transient monocular blindness, meaning blindness in one eye. The interesting about amaurosis fugax is that in this is the one case where the blindness, or the eye experiencing the blindness, will be on the ipsilateral, or same side as the carotid pathology. Now, we can also have a slightly different variety of symptoms when the stenosis or the pathology is interrupting the flow of the vertebrobasilar area. So we remember that if we looked from last week or the week before, we looked at the vessels of the brain, we know that most of our cerebral vessels are really going to be fed off of our internal carotid artery. But we do know that our vertebral arteries come up towards the posterior aspect of our brain, enter the foramen magna, and then join together to become the basilar artery. Now, most of the symptoms we've been talking about are going to be effects of something in this internal cerebral artery, which affects the circle of Willis, or the main cerebral hemispheres. Now, because our vertebral and basilar arteries feed more of the posterior inferior, or occipital type and brainstem region of our brain, the symptoms of pathology in this area is going to be a little bit different. These are a little bit less specific than the carotid pathology. So symptoms could include dizziness. Now, our occipital or our cerebellum, back in the occipital area of our brain, is really responsible for a lot of balance. So if we're disrupting flow to that portion of the brain, then dizziness is expected. Diplopia is going to be double vision, and ataxia. Ataxia is kind of interesting. It's almost like if you've seen somebody intoxicated with slurred speech, stumbling, falling, that kind of describes ataxia, but without the alcohol. So they can have that, again, is another effect of their balance, their speech, things like that, and that's because it's affecting that the cerebellum of their brain. Now, the patient prep and history. The patient prep for a carotid exam is really pretty simple. Your patient doesn't need to do any fasting or any specific prep. The history is a little bit more complicated, and then you're going to also do an exam. So the history of your patient, we need to know the signs and symptoms, and you have to be a very good detective or questioner and able to pull out some of this information sometimes. So now that you know some of the symptoms of TIA versus stroke versus rind versus vertebral basilar deficit, it kind of triggers the questions that you know you need to ask. And we actually have an example of some of those coming up. Now, once you get a good patient history, and if your patient is a post-stroke victim, then you may have to get this from a caretaker, then you'll begin the actual exam. So for a carotid exam, you're going to do a bilateral brachial blood pressure. Now, if our bilateral brachial blood pressures are equal, that would indicate that we have equal flow through both of our subclavians. If we had a decrease of over 20 millimeters of mercury in one side versus the other, that could indicate that disruptions or stenosis in the brachiocephalic or subclavian arteries could actually be affecting the blood flow to the carotid. So it's important to get those to kind of rule out that we have a brachiocephalic or subclavian issue. The next thing you want to do is palpate pulses and strength and symmetry at the carotid, because you may be able to feel a difference right there. At the axillary, which would be, in the armpit, at the brachial, just under the biceps, and in the radial wrist region. And by doing that, you can really look for any asymmetrical changes in pulse, and that can indicate if tends to be, if you're suspicious for a decrease in flow, again, because of a proximal sort of stenosis or obstruction maybe coming out of the heart, out of the brachiocephalic or the subclavian. And then you can also oscillate up the neck. So you can do a high, mid, and low carotid oscillation, as well as a subclaviar. And this is, subclavicular. And this will indicate those, if you hear a high-pitched whistling sound, that would be a bruit. That could be indicative of a stenosis in that area. And all of these are just really good practices that can help you kind of get a very dimensional picture of the patient's situation before you ever start scanning them. One of the best ways to ensure that you're not forgetting anything is to make sure that you have a really good worksheet at your site. And having all of the signs and symptoms questions that you want to ask your patient, as well as their medical history, and then having a place to record your blood pressures, pulses, and oscillation. All of those will help you remember to complete all of these and get that full picture before you start scanning your patient. So we talked about the importance of the questions for the patient history and how there's a lot of them you may want to ask. Some of these you can utilize and put onto a worksheet for a carotid exam, which may really, like I said, guide you in getting a really thorough history. One of the things you want to look at is, or ask the patient if they're being treated for high blood pressure. That might indicate that they have some vascular damage, so you'd be at higher risk for having atherosclerotic changes. You'd also want to ask them if they're being treated for high cholesterol. Remember, we talked about lipids collecting on any of those roughened areas of the vessels, creating plaques. We want to check on asking them if they have diabetes. If so, for how long and how well have they controlled their blood sugars? And if this answer is yes, they have diabetes, they've had it forever, and they have not controlled their sugars, then you're really going to be expecting to see some of those sclerotic changes in the vessels. We also want to see if they've had a heart attack or myocardial infarction or chest pains. This could be indicative of maybe some atherosclerotic changes in the heart. If they happen to have atherosclerotic changes in the heart, they might have it elsewhere in the body. So this would be a good indicator that they are at increased risk. We want to see if they've had surgery or other interventions on their blood vessels, which would again indicate that they have had arterial disease and are at higher risk of having it in their carotids as well. We want to check to see if they've had a stroke or a mini stroke in the past. If they don't know if they've had a stroke or a mini stroke, then you want to ask them about some of their experiences. So have you had weakness or numbness down one side of your body? If so, which side? Have you had difficulty with balance or walking? We know that that would be indicative of vertebrobasilar issues. Slurred speech or difficulty forming words, that could be from either vertebrobasilar or from your internal carotid. Dizziness, nausea, vomiting, most likely that would be from vertebrobasilar. Severe headaches or vision disturbances. So all of these things will help you get a really good overall picture. And again, it's really easy to forget to ask some of these. So getting a really good worksheet going for your site would be a very beneficial action. Now, when we go to position our patients, it's typically beneficial to have them supine with their head a little bit elevated. And you'll find that sometimes it's helpful to place the pillow below their shoulders and have their neck hang just slightly over the back. If a patient has a very short neck, that will help elevate the chin and give you a little bit more working room. We also want to have the patient's chin turned slightly away from the side that you're scanning at that moment. And when they do that, it opens up that neck a little bit for better access. Now, if they turn it too far, it can actually make your job more difficult. So make sure it's just a subtle little turn. One of the things I found most helpful is folding a hand towel in about thirds and placing it on the patient's chest. Especially with women, this can be helpful, but it provides your arm with a nice sturdy base, and so it will help with the fatigue of your hand as you're scanning. You want to use the highest frequency transducer possible. This is usually going to be your 7 to 12 megahertz linear. Make sure that you're selecting a transducer that's going to have an appropriate footprint for the patient. So if they have a very short neck, you might have to try and find a smaller footprint transducer, where somebody with a longer neck, you might be able to use a longer one. Now, when we start looking at the subclavicular area for our subclavian artery, it's not uncommon to have to switch to just a curvilinear just to get the depth behind their clavicle that you're going to need to pick up that subclavian. So don't be afraid to switch transducers a couple times, especially early on in your scan when you're getting the subclavian, and then usually you can do the rest of the more superficial scan with your linear. Okay, so the basic protocols of your carotid ultrasound. You want to include the subclavian arteries, the common carotid arteries, the internal carotid arteries, the external carotid arteries, and the vertebral arteries. Each vessel should be evaluated in both transverse and longitudinal with B mode or black and white imaging, and then they should be re-imaged with color, spectral in all of those planes as well. So how to proceed? So first of all, we're going to start with the B mode evaluation. I find it easiest to begin with your subclavian and work your way up. So you're going to want to evaluate the subclavian in B mode and obtain color and spectral images right there. The subclavian can be really challenging to get. You might also have to, use that curvilinear just for that particular vessel, and you're really going to have to angle down. So I find that once you find the vessel, it's easiest to get all of your imaging of the subclavian out of the way in one shot before moving on to the rest of the carotids. So obviously, when you're doing a carotid exam, you're going to do the right and left side in every single exam. So you would typically start with whichever side you choose, and you're going to get those images first in B mode, then with color, and then with spectral of the subclavian on your side of interest. Next, you would go to B mode, into the carotid. When you're in the carotid, what you're really looking for is to demonstrate smooth vessel walls in both your transverse and in your long images. You want to make sure that you see the intimomedial layer or interface clearly and that you see that it's visible and uniform. If you see enlargement of something, that's going to send off a little red flag for you. And then you want to make sure that your lumen is anechoic. Sometimes to get this accomplished, you may have to adjust your dynamic range to make it a little bit more contrasty. You definitely want to make sure that your depth is set appropriately, that your gain is set appropriately. You also want to pay close attention that you're setting your wall filter correctly when we get to the color. So just practicing your good physics practices is going to really make you have some better imaging techniques for your to demonstrate these normal B mode characteristics we're looking for. Once you have a nice image, you're going to want to sweep through the carotid system in transverse with B mode. So you're just going to want to start right down there at the subclavian in transverse, and you're going to want to follow it up, evaluating it in live time all the way up through the bifurcation and demonstrating the ICA and CCA. Once you've had a really good look at this, you've kind of given yourself an overview of what you expect, then you can go back and you can take your CCA images, your common carotid images, in proximal, mid, and distal, demonstrating any sort of plaques or abnormalities that you may have seen. Once you have your CCA demonstrated in proximal, mid, distal, at the bulb, and at the bifurcation of the ICA and ECA, then you can go to long. So again, with long, you're going to want to start first with just a general evaluation. So make sure that that inferior aspect of your transducer is wedged kind of down under the clavicle to where you're demonstrating its confluence or its origin at the subclavian, or on the left side at the aortic arch. And you're going to want to start right there and demonstrate it in its most proximal, follow it all the way up in live scanning through the mid, through the distal, view the carotid bulb, and then shift slightly to see the ICA and then the ECA. And once you have a good overview of that, then you want to go back and you want to get your pictures and document your proximal, mid, distal CCA, the bifurcation just past the bulb, and demonstrate the ICA and ECA branches. Once you've completed that, you want to make sure that you've identified and documented any intraluminal echoes that represented plaques or other intimal defects, and then document any other areas of interest in your beam mode before moving on. Now here's some demonstrations of really where you're looking at. So if we look at our aorta, here's our aortic arch, and if I'm watching my aortic arch, the first branch to come off of that would be my right brachiocephalic. As that right brachiocephalic comes up, it's going to bifurcate into my right subclavian and my right carotid. It's right there at that bifurcation. You want to start documenting that subclavian and the carotid and the brachiocephalic if you can. Okay, now if we look here, you can see this is actually the aortic arch. They've had to really increase their depth here to kind of catch onto that arch, but that's kind of what you're looking for. If you can get that image, if you can put color in there and then document the subclavian and the carotid coming off of there and take Dopplers in those three general areas, that's going to tell you that you really got to the origin of the vessel. Now when you're in transverse, your image should look a little something like this. So we see if this is the CCA at mid, it says, this would be the internal jugular vein. The jugular is going to be compressible. The CCA will not. Make sure that you're staying on the vessel of interest and not wandering between the two. So you're going to follow that CCA up from its origin, hopefully way down here at the aortic arch range, and follow it all the way up in transverse, documenting images at proximal, mid, and distal, bulb, and then at the bifurcation. When we look at our CCA in long, it should look something like this, where we can kind of make out these intimal lines. We've taken out all of our echoes of the lumen, and we can really almost appreciate that tunica media that separates it from the jugular. Here you see it a little bit better where we see that intima and media interface, and here's our lumen. So you want to make sure you're staying elongated on this, evaluating all the way through and long, and then going back and obtaining that proximal, mid, and distal. You can tell right here we're getting into the bulb, so we're at the distal end of that carotid artery there. Next, you're going to go ahead and add some color. With our color, we want to utilize good color, standard color practices. So you see in this image here, we have our angle, our Doppler angle, and it is shifted or directed towards the patient's head. This is going to ensure that we're not hitting that carotid vessel with 90 degrees. If our color beam is hitting that vessel at 90 degrees, we will not get adequate fill. So they're having good practices there by steering their box one direction or the other. They've also set their scale so that, inverted their color so that they're making sure, because it's flowing towards the head, it's arterial, that it's demonstrated as red. Their color scale is set appropriately because the whole vessel is red. If it were set too low, we'd have aliasing and you'd see some blue color in there. So they've got a good color scale, they've got a good angle, and they also have set an appropriate wall filter. So we know that our instrumentation can detect motion, whether it be from blood flowing or motion of pulsatility in the walls. And so in order to prevent the bleeding out or the detection of that pulsatility in the walls here, you want to set your wall filter so that only within the lumen is demonstrated with your color flow. And then finally, the color gain is set appropriately so that we're getting nice fill in that vessel. Now, once you have all of your settings done appropriately, you're going to evaluate and image the proximal, mid, and distal sections of the CCA, the bifurcation or the bulb, the bifurcation of the ICA into the CCA in long with color. Now, some sites may request that you do this in transverse with color, but most sites I'm familiar with are really just requiring it in long with color. Now, once you've completed that, or as you complete that, you also want to get your spectral. So as you're following this vessel up, let's say you're just going to follow it up in color from the proximal all the way to the distal, look at the bifurcation, and then your color evaluation is done. The next thing you can do is go back, kind of start over, get it back in color again, and as you advance it up, take that image in long proximal with your color, and then add your spectral in. And take that image right there. And as you follow it up to the middle, then you take your color and spectral there. And as you get to the distal, you do your color and your spectral there. And it keeps nice organization for you and the radiologist to evaluate. Plus, you've already done your first evaluation in color. Now, it does make sense, and it is recommended that you always walk your Doppler through the whole vessel, all the way up the vessel as you're going through it, looking for any spikes or changes as you move along that vessel. So once you've gotten through the vessel, proximal, mid, distal, with color evaluation, with spectral evaluation, and with documentation of color and spectral, then you're going to go into the bulb and then into the bifurcations. Now, if you happen to encounter any sort of stenosis along the way, you would want to walk your gait carefully through that stenosis, and you would want to record the highest velocity you can find in that stenosis. And sometimes that's easiest to do by listening to the highest whoosh you hear come through. So here we see they're walking through, they're getting their spectral. After you obtain each of your spectrals, you're going to want to take a peak systolic velocity and an end diastolic velocity. So you're going to place your caliper right here on the peak, and you're going to place your caliper right here on your end diastolic, and that is going to give you your peak and end diastolic. Most of the time, systems will have a calculation package in that you can enter this in so that when you go to get your velocity numbers at the end of the exam, they're all neatly organized on a little report. Now, the purpose for walking your gait through a stenosis is that the higher the stenosis, the higher the velocity is going, or the more significant the stenosis, the more the radius reduction of your vessel is, the higher your velocity is going to be. And so by walking it carefully through that stenosis, you're going to be able to identify the highest velocity peak so we can accurately classify the degree of stenosis. Okay, now once we're doing our color and our spectral, we're going to be getting spectral waveforms. Now we're going to evaluate that all the way up the common carotid, and then when we get to the ECA and the ICA, we're going to start to see some changes. We're going to need to evaluate both the ECA and the ICA with color and spectral. However, the ECA, we really look at color and spectral only in the proximal area of the branch. So as we look at the CCA here, you'll see that the CCA is actually much higher resistance than we see in the ICA. In the CCA, we have a sharper systolic upstroke, and then as we go into end diastole, the motion of that forward motion of our blood flow is much lower than it is in our end diastole of the ICA. That indicates that we have a higher resistant tissue bed that our ECA is feeding, which makes sense because our ECA is feeding a lot of our facial muscles, our thyroid, things like that. Those are not as low resistance because they don't have the same kind of metabolism that our brain has. So our ICA that goes to our brain is going to be very low resistance. Our ECA will be a little bit higher resistance. And that's one of the ways you can determine which one is which when you're right at that bifurcation. The other thing is that the ECA does have additional branches, extracranial branches. So if you see branches coming off of one of these vessels, then you automatically know it's the ECA. The other thing about the ECA is you can do something, as we're going to show you here in the next slide, called temporal taps, where you tap them right in front of the ear, and you will actually see that tap demonstrated on the waveform of the ECA, but you won't of the ICA. So that would indicate that, yes, you are in the ECA. Okay, so we're going to evaluate that ECA in the proximal region with spectral and color, and we're expecting it to be slightly higher resistance than in our ICA. Then we're going to evaluate the proximal, mid, and distal ICA with color and spectral Doppler. Now the proximal should be pretty easy because it's right there at that bifurcation. What gets more challenging is when we're getting into the mid and the distal. Sometimes it can take a lot of adjustments with your color to be able to follow that vessel as far as you can. One of the things, as you'll see the ICA does, is as it comes back to about this region, it starts to sort of go posterior away from you. And so it can be harder to get blood flow. You may have to adjust your angle of your box. You might have to increase your color gain. You might have to decrease your scale, which will make it more sensitive. And ultimately, sometimes you have to go to power Doppler because it is not angle dependent. And sometimes that's the only way you can really follow the ICA, especially if it's very tortuous and going very deep into the patient. So it sounds easy. All you do is go get that proximal, mid, and distal ICA, but the application of it can be much more challenging. But the best favor you can do to your patient is by getting as distal up into the ICA as possible. Whenever you're taking these ECA and ICA measurements, just like you did with the common carotid, you want to be doing their peak systole measurement and their end diastole measurement. If you happen again to come across a stenosis, specifically in the ICA, you want to walk your gait through the stenosis and make sure that you're obtaining the highest velocity for your calculations. The other thing you do have to be very aware of is to always be remembering on these good Doppler practice. So if my vessel lies across my image this way, I need to get my gait in the center of the vessel, and I need to make sure that my Doppler angle is parallel with the vessel wall, and that the readout of my Doppler angle, which is generally up in this region on your screen, you want to make sure that it's between 0 and 60, 30 to 60, or 0 is ideal, but 0 to 60 will work. So remember, 0 or 30 to 60 is ideal, must be parallel to the vessel. Now, sometimes changing the angulation of your color box will help change those angles as well. So don't be afraid to change those to see if it makes getting those appropriate angles a little bit easier. All right, so why are we using color and Doppler? So color Doppler should be used to help identify a number of different things. One of those things is to help identify aliasing. So remember, aliasing occurs when we're undersampling with our color, and that aliasing demonstrates itself as if we had our carotid represented in red, and yet the center of that carotid's nice laminar flow appears blue, that would indicate that our sampling, that we're undersampling, and that we're aliasing or providing false information. So in order to correct that, you could increase your scale. Another thing that color Doppler can be really helpful in is demonstrating turbulence. So we know that if I have a vessel and there's a large stenosis in this vessel, as blood enters that stenosis, it's number one, going to flow faster because of that narrowed area, and the law of continuity tells us that the speed has to increase in order to move as much flow or blood flow through an area, even though there's less space to do it in. Now, once it gets through that area, once this reaches the end of the stenosis, all of a sudden this blood has all kinds of room to move, and so we're going to start seeing some turbulent changes. That will be represented by what they call a mosaic, or a mixture of colors here, because we're getting forward movement mixed with backward movement, reds with blues, and so on and so forth. And so we want to use our color to demonstrate those turbulent changes. We also want to use our color to demonstrate maximal velocity. So color scales are really based off of speed. When I look at the top of my scale, it will have reds. If I have it set red forward, it will have reds from lesser bright hues to brighter hues. And depending on the speed at which that particular area of blood flow is traveling, it will assign a hue. So if I'm looking through this little stenotic area of this vessel, I would expect it to all demonstrate red, but the areas that are moving the fastest are going to be the reds that are more towards the top of my scale here. So you're going to see that. It can help you identify where you want to put your gate when you're trying to get that maximum velocity. Speckling can also indicate a color bruit, or something like you're seeing here with this turbulence. Now, pulsed wave or spectral Doppler, same thing, is going to be used to measure those flow velocities. And we'll talk about in a minute, it's really based off of the flow velocities, how we're able to classify any sort of stenosis within the cerebral system. So we want to make sure that we're measuring very accurately, that we're following all the best standard practices of Doppler, a spectral Doppler, with our angle, with our gate, with our selection size, to make sure that we're getting the most accurate velocities we can, demonstrating them on a nice appropriate size scale so we can measure without squinting and straining our eyes and get accuracy there, and then documenting the waveform contours. So sometimes you can learn as much from a waveform about what's upstream or what's downstream as you can learn from seeing a stenosis or a pathology itself. And we call that indirect assessment. So here's an example. We talked about how we differentiate the ECA and the ICA. The ECA has multiple branches within the neck, as I mentioned. So if we find one of those vessels after bifurcation has a bunch of branches, we know that's the ECA. Now, more often than not, it's hard to see those branches are pretty small, and so lots of people will go to the temporal tap, where again, you tap that patient just in front of the ear, and you will actually see changes in blood flow on our spectral here with the ECA. Additionally, the ICA is typically larger, and it contains the bulb. So the ICA is going to be really more, start more at the bulb, and then it lies posterior to the ECA. So ECA, smaller, anterior temporal taps, ICA larger coming off of the bulb, and then posterior, and then it's going to dive right down into the brain. Okay, now one other thing we have to be considerate of when we're scanning in color and spectral, and actually we're going to be looking for this to evaluate during our image, our carotid evaluation. If we backtrack just a tiny bit, as we followed our carotid artery up, the common carotid artery up, proximal, mid, and then at distal, we see that the origin of the bulb. Now at the origin of the bulb, we actually have this vessel coming in, and then we have a dilatation or the bulb. And because of that bulb will then basically turn into the ICA, and then we have our ECA come off there. So because this bulb is a sudden dilatation, we would expect to see some turbulence, just like we would see post-stenosis. So you see the blood flow start to curve around and then get going straight again. Now here you see it with the reds and blues. So you're seeing forward motion here. It whooshes around, reverses motion here, and then gets going straight again. That is actually a normal finding in a carotid bulb, and you want to see that. We call that anatomic color separation. Now, if we were to look at this on transverse, you would see basically half of the artery filled with red and half of it filled with blue. Now, this tells us that that bulb is larger than the vessel leading up to the bulb, which is a good thing. If I were to have a lot of plaque in my bulb, it would narrow that vessel and we would lose that color flow separation. So that's a normal finding of turbulence that we can assess in the color bulb, in the bulb with color and with spectral, that's going to tell us of actually some normalcy in the anatomy and the functioning of the carotids here. So here you see, here's the distal CCA coming in, here's the bulb, we put color on, we see that normal anatomic separation of flow. If they put a spectral Doppler gate in the vessel right here, we would see normal low resistance flow moving forward down the proximal ICA. But if we put our gate right here in the middle of that bulb with lots of turbulence, we're going to see forward motion, reversed motion, and that would be expected. So that's something that's actually good. Remember, if we're losing that, it's probably that we have stenosis in the bulb. Now, the common place that we're going to start accumulating plaque in the carotid system is going to be at that bulb or at that bifurcation. When we have high lipids, we're smokers, we have diabetes, all of those risk factors, we're going to have a lot of sharp objects in our blood. We're going to have a lot of lipids to catch on things. And if we look at the flow coming into our bifurcation, this is one of the places that blood is going to be crashing into that wall before going down the actual ECA and ICA. So because of that added impact there at the bifurcation, we're more likely to get damage to the tunica intima. And then we're going to, on that damage, we can accumulate plaques. So this is one of the first place plaques will start to show up, and so it needs to be, looking for this normal flow separation can be very helpful in assessing whether there's plaques there or plaques that are at least hemodynamically significant. We would find those there. Okay, so we've done most of our exam at this point. So we've talked about, we're going to start at the brachiocephalic or subclavian and assess that. Then we're going to go up our carotids in transverse B mode. Then we're going to go up our carotids in long B mode. We're going to image them in transverse and long B mode. Then we're going to image them, or we'll evaluate them with color. And then we're going to evaluate and image them with spectral and color. And we're going to measure our spectral. We're going to look for that normal blood separation in the bulb, and then we're going to identify which vessels are ECA and our ICA. Our ECA should be anterior and respond to temporal taps and have a higher resistance flow. Our ICA is going to be larger, posterior, with lower resistance flow. Our ECA we only need to image in B mode at the proximal region with color and with spectral at the proximal region. Our ICA, we need to image proximal, mid, and distally in B mode with color, with Doppler, and assess our peak systole in our end diastole in all of those regions. We also need to make sure that we're utilizing best color practices to pick up very low, slow flow or difficult or blood that's difficult to obtain, blood flow that's difficult to obtain. Once we have all of that done, our carotids are mostly done, complete. So then we would go to our vertebral arteries. And the easiest way to access your vertebral artery is to basically start at the midline of your thyroid and start angling your probe and sweeping laterally. And when you do that, you're going to come across your intervertebral foramina bones. So you'll see bones, and behind those little ridges of bones, you're going to catch your vertebral artery. Now, once you have found that vertebral artery, you only assess it in one region. You're going to assess it in B mode long, in long with color, and in long with your spectral Doppler. And you're going to measure your spectral Doppler, your peak systole and end diastole there. Now, this is really important that you are also evaluating your color, utilizing a correct color box, making sure that that blood flow is actually going towards the head. There's something we'll talk about in a minute called a subclavian steal that actually reverses the vertebral flow. So you have to think about your color box directioning and making sure that your flow is truly going to the head. So if I had red towards, blue away on my scale, and I had my color box set at this particular angle, if color were to be, or if the blood were to be flowing towards my head, it would be going this direction and would appear red. Okay, my scan lines are coming this direction, so my blood flow would crash into those scan lines, not run from them, and that would cause a positive Doppler shift, and it would appear red on my image. If I had the same setup and yet my blood was flowing away and my scan lines were chasing after it, that would cause a negative Doppler shift and it would apply a blue hue. Now, what would be the temptation in that case is to simply invert my scale here, but that would incorrectly demonstrate that blood flow as toward the brain when it was going away. So make sure that you're very precise with your color evaluation of the vertebral to assure that it is headed towards the brain as it should be. Now we'll talk about a little bit of the pathology that can occur. We briefly discussed this, but we know that plaque is one of our biggest concerns in the cerebrovascular system. So plaque originates typically at that bifurcation, as I mentioned, because of basically that's where our blood goes crashing into the walls and it disrupts that intima, and then it gives a good place for lipids and other things to start to stick. Now, one type of plaque is going to be fibrous. You'll see that this is a fibrous plaque. It's probably some scar tissue building up where some damage had occurred. We have some other types of plaque that we'll talk about in a second, but usually when we see the earliest stages of plaque, we're really seeing that fibrous cap or those changes. Now, these can be a little bit difficult to differentiate from thrombus, so be prepared to turn your gain up and down and really make sure if it's fibrous tissue, it's going to be more homogeneous. If it's thrombus, you might actually see it have a little bit more movement or, a flap. So make sure you're evaluating it, determining if it's fibrous or if it's thrombus. As this sort of develops farther along, lots of these plaques will become more complicated. They can be classified as smooth or irregular. In the past, they used to use this classification called ulcerated, which basically would mean it's mixed and the intima is irritated, hence the ulceration. Now they really discourage us from using that terminology and would prefer us to really refer to it as homogeneous or heterogeneous. So here in this fibrous cap plaque, I could look at that and say it's really a pretty homogeneous plaque. If I had something that had a lot of variation, calcification, hypoechoic, hyperechoic areas, then I would definitely refer to that as heterogeneous. Now, we want to extensively characterize the plaque with our B mode. We want to look at it in long, we want to look at it in transverse, evaluate it with different gain settings. And then we want to look at it with color too to see how exactly it's affecting the color or the blood flow through that area. Sometimes some of these plaques can have an interplaque hemorrhage, like you see maybe here in this fibrous cap. This one's not so much, but here this one looks a little bit more heterogeneous. It's hard to know, without actually assessing the vessel external to the body, what exactly this plaque is made up of, and therefore that's why some of our B mode image descriptors can be a little bit controversial. So we want to make sure that we're just using what we know to be accurate and not going out on a limb too much with some of those terms. Anytime we have an interplaque hemorrhage, it's more likely that that plaque is going to be pushed off of the wall and break free and cause an embolus. So that's one of those things we're really looking for when we're classifying those heterogeneous plaques. Here's some examples. Excuse me. Here's a heterogeneous plaque. Obviously, it has mixed. It's got calcifications. It's very difficult to assess this just in long and know if there's any opening left in that vessel lumen. That's why we have to classify and look at these plaques in long and in transverse. Now, whenever you have calcifications in the plaque, it can be very difficult to demonstrate flow through there. It's essential that if there is any flow getting through a plaque, that we document it. So make sure in this case, you probably wouldn't see any flow here, but if you were getting flow posterior to it, we would know flow's coming from somewhere. So you'd have to be trying different, perhaps moving to the side of the vessel and angling in through a different window or something like that may give you the ability to see flow through here where it's not being shadowed out by those calcifications. Some technologists find it very helpful to use B color or different, this is a sepia tone here. Most machines will have that option. They'll be often called by different names. So depending on your manufacturer, you could identify what your B color mode would be. And this would just, rather than applying gray hues to all the grayscale, it would apply, in this case, sepia hues. And you can see how that does probably make that plaque stand out a little bit better. Some radiologists will not appreciate this, so you want to make sure it's okay with them before you start taking a lot of images that way. Now, here you can see how you can even use your regular color mode, or excuse me, your color Doppler over the top of these different B mode maps, and you don't have any issues with that. This indication here, this line pointing here, would indicate there's actually a hemorrhage in this plaque, meaning it's much more dangerous than maybe just a fibrous cap plaque. Other interluminar defects besides just our plaque. And I don't want to say just plaque because it's a serious issue, but that's all we typically think about when we're thinking about carotids, but other things can happen. One of the most significant problems can be a dissection. So when you have a dissection, your tunica intima is separated from your tunica media. And over time, it's going to start pumping blood into that, what we call the false lumen, because it has nowhere to go. Eventually, we hope that that intima will reattach or stay attached to our tunica media. So in this case, you see the true lumen is here. That's the original vessel. However, the false lumen, we're pumping blood into this basically pouch with no end, and we call that the false lumen. Now, over time, with that pressure coming off the heart, pumping blood into this end, it can continue to tear away that, that intima away from the media farther and farther till you can dissect all the way up to the brain. Or you have such a significant dissection that all of your blood is going into the false lumen, none is in the true lumen, and you're suffering severe lack of perfusion in the brain. So our arterial dissections are very traumatic. They're very serious. This would be an emergent condition that I'd immediately let the radiologist know about. so that they could take a look and take immediate action for these patients. So usually these are started by an interrupted intima. Now, it can be from a number of different things. There's something called Marfan syndrome, which I won't get into great detail, but it's a connective tissue congenital disease where these layers separate more easily. That puts you at higher risk for these. But there's other things like a recent procedure, trauma to the vessel, things like that can cause a dissection as well. So some of the things we're looking for in these dissections, first of all, we're looking for a flap or an echogenic line. We want to see that intima away from the tunica media, and then we want to see if it's containing blood, and if that blood is ending at that false lumen is ending at a pouch, or how far it's extending. Sometimes these can actually separate in a spiral pattern. It won't necessarily separate straight up the vessel, but it'll kind of wind around the vessel like a spiral. And in that case, you might see a spiral pattern mixing of, or spiral pattern when we see the red and blue blood flow separated. These can begin at the aortic root if spontaneous, and usually if it's traumatic, it begins at the area of trauma. So again, significant emergent situation you want to get addressed right away. Okay, another intraluminar defect that I kind of briefly mentioned that has a lot of similarities to the appearance of our fibrous plaques is going to be carotid artery thrombosis. These are pretty rare, and they appear, like I said, very similar to the fibrous or soft plaques. So with these, you really want to adjust that gain up and down, looking for any sort of flapping end, and document it as thoroughly as possible. Lots of times the thrombus, that's just a blood clot. Lots of times that's going to be a result of some type of trauma. So getting that patient history is going to be important as well. Another type of defect would be called an iatrogenic injury. Now, I'm sure you're familiar with this, but sometimes if we haven't thought about iatrogenic injuries for some time, that term can kind of disappear. So an iatrogenic injury is an unintended consequence of a medical procedure. So perhaps they were trying to do a thyroid biopsy and actually nicked the carotid, something like that. An unintended consequence of a medical procedure. So here's an example of an iatrogenic injury to the carotid vessel. You see that they have created an unusual or an incorrect pathway here in the carotid, and the carotid is now leaking blood into the interstitial tissue. It can cause things called fistulas, which are abnormal connections between one body part and another, or it could cause something like a pseudoaneurysm, where this will eventually become encapsulated off and yet appear almost like a saccular aneurysm next to the vessel. So for any of these, whether it be a dissection, a thrombus, an iatrogenic injury, you're definitely going to want to get lots of Dopplers through the area of interest. You want to get Dopplers through the abnormal area, and those are going to help make your case for what's going on with these patients. Okay, I did mention how you obtain your spectral Dopplers. We have to pay great attention to following all of the appropriate practices in this. So just a quick review, some people struggle with this. Most likely you guys have been scanning for some time and won't have any issues, but we want to look at here. You see the color box is steered. When that color box is steered, it automatically is going to steer the spectral box with it, or the spectral sample with it. So they steered this color box to the left. That means our scan lines are traveling to our left. That means anything that is going towards the head would be running away from my scan lines, causing a negative Doppler shift. So the only way this could be read is if it was going away from my scan lines towards the brain. And we have our red below the line indicating a negative Doppler shift, as we would expect. So this is good forward motion, good cranial flow, and we can assess that by just evaluating our color there. Secondly, we want to look at our gate size, our gate or our sample size. we want it broad enough to get a good sample, but not so broad it's going to pick up turbulence. We want it centered to the vessel, and this technologist has done a great job with that. We also want to look at the Doppler angle. Their Doppler angle is nice and parallel to the walls of their vessel. If it wasn't, they'd have to heel and toe to get that to align with the vessel walls. They have a good wall filter set because I don't see any bleeding of the color into the wall. And if I look up here, it appears that they have a 60-degree Doppler angle set. So we know we want to be at 0 or 30 to 60, and they're at 60. So the values they're getting down here in their spectral Doppler are going to be very accurate. Now, if I'm going to go in and I'm going to take my measurements for my common carotid, external and internal carotid, as well as my vertebral, I'm always going to measure at the maximum here, the peak systole, and right here for my end diastole. I also want to make sure that my spectral scale is appropriate. So I want this waveform to take up pretty much all of the scale I'm providing. Sometimes you'll see people with their spectrals way down here because they have their scale set too high, and it can make it way more difficult to measure these very accurately. So setting that scale, the technologist has done a great job setting that scale, and it's going to make their job much easier as they're trying to do their measurements. Now, if we look at what we have outlined here on this little slide, it says this is the sharp peak. So this is when my heart contracts, pushes that blood flow forward with maximum velocity. This is going to be my peak systole. As that heart exits systole and enters into diastole, we're going to see the blood flow slow down, and then wind Kessel effect, or that hydrostatic pump, that potential energy in our vessels cause them to squeeze and push the blood forward again, maintaining forward motion. So and that's right before my systolic upstroke begins again. That's where I'm going to take my end diastole measurement. Now here you see the blood flow is forward throughout all of these cycles. That would indicate a relatively low resistance. You also notice that we have what we call an open spectral window. So these black areas below the spectral lines are really indicating that I have a nice, neat, pure signal from the center of my vessel. It's demonstrating that this line here, at this moment in this time, it was obtaining information from cells going at a maximum of 70 centimeters per second, all the way down to a maximum of, let's say, 35 centimeters per second. So all the cells in that range at that particular moment that this line was drawn were traveling in that range from 30 to 70 centimeters per second. Now, if this technologist had opened up their gate to include all the vessel, or even beyond the vessel, they would see a much broader range of velocities produced at that one moment. Maybe maybe those blood cells having friction against the vessel wall would be going nearly 0. You'd see that line much longer from all the way to 75, 80 to 0. If we had many of those vessels together, or excuse me, many of those large sample readings together, you start to see what we call spectral broadening, or a closure of that window. So technologist is doing pretty much everything right here. We've got a good spectral window. We've got forward flow throughout diastole, indicating that there's minimal resistance up ahead. We have good systolic upstroke, indicating that when that heart pumps, that blood's got somewhere to go and it's going and getting there fast. Okay, so our Doppler waveform, so that's assessing the waveform itself, but what's the waveform telling us? Well, the waveform is telling us about what's happening at this area at a particular moment in time. Now, it also tells us, just as we know, like as you're coming, let's say that you're on a rafting trip and this is your river that you're rafting down, and you're floating along going nice and slow for a while. And then all of a sudden you start speeding up. That change in how fast you're moving indicates that there's something ahead making things go faster. And then pretty soon you drop down a waterfall. Now you're going really, really fast. Well, you had indicators previous to that waterfall that were like, hey, heads up, something's coming. When you get to the end of that waterfall and you reach the bottom of it and you hit water, all of a sudden you get a lot of turbulence here. It's really the same idea when we're looking at our Doppler flows. You don't have to be at in this turbulent area to tell you that you have just been down a waterfall. You'll know that ahead of time. You don't have to be in the waterfall itself to know that there's a waterfall there. You can tell that ahead of time. So same kind of idea with our blood. When we're looking at our spectral Doppler, we're not just, while we're gaining information from this one tiny region, that's not all we're gaining. We're gaining indicators of what's happening upstream and what's happening downstream. So what we've been through and where we're going. And so we always want to be taking those two things into consideration as you're seeing these waveforms pop up. Okay. So now with a nice, let's say low resistance waveform, so say our internal carotid, we know it's very low. We have a nice systolic upstroke, forward motion through diastole, and so on and so forth. Now with our external carotid, we have a little bit more resistance. So we get this nice systolic upstroke, a much lower diastole, and so on and so forth. Now, if we know that the common carotid is feeding both of these arteries, the common carotid then is going to look like ICA plus ECA. It's going to have characteristics of both of these waveforms. So we see this really high, nice systolic peak, good forward flow, and yet the end diastole is going to fall a little bit closer to zero than it would in my ICA. And that's what I expect because I know what's upstream, what's ahead. Okay. Now the other thing is what's behind. So we see that our Doppler waveform contours can change if we don't have cardiac output. If my heart is barely beating, there's nothing strong enough to push a good systolic upstroke. And so you'll see this less sharp peak coming, more of a tardus parvus. I think about it as being tardy, tardus parvus form that looks something like that. That could be indicative that there's some sort of cardiac output. It has nothing to do with where you're at, but the pressure getting the blood there isn't available because the heart's not working. Vessel compliance can also be indicative or indicated in your waveform. So we know that our diastole forward motion is highly dependent on the Wind-Kessel effect or the hydrostatic pump. It means our vessels, our arteries have to be compliant enough that they can stretch out when they're filled with blood. And as that pressure of systole is over, they're able to contract and push that blood forward. If you have really hardened vessels, they are not going to be able to expand and contract and stay compliant and help during that end diastole. So you may see a tapering off or a limited end diastole forward motion because we don't have the vessel compliance there. And then finally, our waveforms are going to tell us what's upstream. That's all about what's behind us, but what's upstream? Now, if I know that my internal carotid artery should look something like this form up here, and yet I don't see any stenosis in my internal carotid, and yet it's looking more like this, where my blood flow is not continuous in diastole. That's going to tell me that there's some sort of resistance up ahead that's overcoming that Wind-Kessel's effect's attempt to push the blood forward through the whole diastole. So this would be indicative that there is some sort of stenosis up ahead. And we're going to look at some examples of this. Okay. So our normal Doppler waveforms of our CCA, ICA, and ECA are all going to have brisk systolic upstroke, as we demonstrate here. They're going to have a sharp systolic peak. So that means systole is ending very rapidly, and we're going right into diastole. And then they're going to have a clear spectral waveform, not a lot of spectral broadening. and nice open windows. So we wouldn't want that spectral broadening. We want these nice open windows, and that's what we can expect. We know that the ECA is a little bit higher resistant, the ICA is lower resistant, the CCA is a combination of the two. ICA is going to have the highest diastolic velocities because there's nothing resistant that blood flow, because our brain wants all the blood it can have, and it just says, come in, come in, come in. And so all of that forward motion is going to continually occur all the way through diastole. Now our ECA is going to have a little bit more resistance at those arterioles in those distal vascular beds, because those muscles of our face, some of that anatomy is not going to need as much blood flow, and so it's going to have a little bit more resistance and demonstrate that lessening diastolic blood flow. And like I said, the CCA is going to be intermediate. The brachiocephalic, which comes off of our aortic arch, is going to have higher resistance because it's going to not only feed the vessels of my vertebral and my carotid, but it's also going to feed all the vessels in the arms, which have a high muscular component and are going to be more resistant. So the brachiocephalic definitely going to show greater resistance. Don't be alarmed when you see that. So here's some examples. Here's our ICA. You see very nice brisk upstroke, very high diastole. Here's our ECA, nice crisp upstroke, still forward motion during diastole, but much lower than it was for the ICA. And then here's our CCA. It's the marrying of the two vessels that lie ahead. Neurologic feedback. So we do have some receptors in our carotid system that are going to provide neurologic feedback, which will affect our respiratory rate and some other things. So within that carotid bulb at the distal CCA, there's a slight focal dilatation. And there's something called baroreceptors in there that are going to assist in blood pressure. So if it's recognizing that the blood pressure here is low, it will do things like stimulate vasoconstriction, maybe increase renin production, things like that, which will then trigger attempt to help increase the blood pressure. Also, we have carotid bodies nearby, basically at that bifurcation into the internal and external, and these are chemoreceptors that are involved in respiratory rate. So these are going to be basically looking at the oxygen levels of our blood flow here, and they're going to increase and decrease respiratory rate to keep those oxygen levels where they need to be. The bulb typically involves the proximal ICA, but can also include the distal CCA, proximal ECA, or all vessels. So that's just one thing to keep in mind, although most commonly it's right here at the origin of the ICA. Okay, so what do we do when we have a stenosis? We are going to encounter stenosis in any of our vessels here in the carotid region. So what we want to do is, if we find a stenosis, we already talked about how to classify it according to our B-mode imaging. And so we're going to want to look for it. We're going to want to document its location. We're going to want to document its appearance, whether it's homogeneous or heterogeneous. We're also then we're going to need to go to our velocities to determine how significant that stenosis is. So here we are looking in our distal common carotid, if you see at our top view here, and actually it looks beautiful. We have tunica intima, tunica media, we have a nice wide lumen, and yet when we put in our spectral, everything looks good here. We have good angulation, and yet when we look at our spectral waveform, we see that we have even early diastolic reversal, very low end diastole to no end diastole. This would indicate that this is a high resistant bed up ahead. So we're going to expect to see some stenosis somewhere coming up. Now, if for some reason there's a stenosis up ahead and yet collaterals have formed to bypass that stenosis, be aware that our vascular waveform here in our spectral Doppler can look completely normal because the stenosis has been bypassed with collaterals. But if no collaterals have been formed, this would be a very indicative high resistant waveform pattern that would tell us something lies ahead. Now, once we find the stenosis, we need to be very careful to document whether it's still patent or if that vessel is occluded. As long as there is any sort of blood flow getting through that stenosis, that patient would be a candidate for surgery. Sometimes those calcifications can be really difficult to see around, so it can be really hard to prove blood flow in these regions, but it's essential. If it's completely occluded, that patient is no longer a candidate for surgery. So make sure you pull out all the stops, whether it mean trying different angles, trying different windows, increasing your color gain, decreasing your color scale, moving to power Doppler. Do anything you can to try and pick up blood flow in a stenosis. Once you are able to find that blood flow in that stenosis, you're going to want to look for any jets and take you're going to want to take your spectral Doppler and you're going to want to walk it through, leaving your spectral Doppler on as you're moving through live, all the way through that stenosis, waiting for the peak. And wherever that peak is, you need to record that as your peak systole, because that's going to help classify it to a certain percentage of stenosis. Now, after that stenosis, you're going to expect to see turbulence. Turbulence is going to be demonstrated as spectral broadening. And then distal to stenosis, this is where it gets kind of tricky. We say that bad line there. We say that the law of continuity will make the blood go so fast through this stenosis that it's going to move the equal amount of flow through this stenosis in one moment than it does in the open lumen down here. Well, at a certain point, that stenosis is so significant, we call it a hemodynamically, it causes hemodynamic changes, which means no matter how fast it moves that blood, it cannot get as much blood through that region as it could through the lumen over here. Therefore, the pressure of blood after it's leaving this turbulence is pushed by a lot less pressure. So what we'll see post-stenosis is something like this. We see this very slow systolic upstroke. That's referred to as tardus parvus. We see this very low resistance. That's because there's not enough blood there for any of the tissues to resist it, okay? And you see this decreased pulsatility, very low, slow flow. And that's just basically because there's just not enough blood flow there to demonstrate the normal patterns. You'll see spectral broadening because that blood's going to be flowing a number of different velocities. And that's kind of the gist of what you'll expect when you see these stenosis. I briefly want to talk about a subclavian steal. I mentioned just a little bit how when we're assessing the vertebral artery, we really want to make sure that the blood through that vertebral artery is going towards the brain. There's something called a subclavian steal, where if my patient's aortic arch looks something like this, and the brachiocephalic comes off the right, it splits into the subclavian and the carotid. If, let's say for instance, my brachiocephalic is nice and open here, but then I have a total occlusion of my subclavian between where my carotid comes off and where my vertebral comes off. So here's my carotid, here's my vertebral. In this case, I'm going to provide lots of blood flow to my brain. I have the circle of Willis to convert blood flow from, up to my brain, and it can act as a natural collateral. But what's going to happen is this occlusion is going to prevent any pressure or any forward flow coming up my vertebral. It's also going to result in a lack of blood flow in my whole arm because that's the next place my subclavian is going. Now, because of this, what's going to happen is that blood is going to go up to the brain through my internal carotid. It's going to circulate through that circle of Willis. And because there's being no blood or low blood pressure provided by the vertebral, it's actually going to start going down that vertebral and out to the arm to feed the arm. So it's basically that occlusion in your subclavian is causing your arm to steal blood from the brain. Now, because of this, we can get a reversal of flow in that vertebral artery. Now, this doesn't just happen overnight. This stenosis doesn't go from nothing to 100 immediately. So as the stenosis gets gradually more hemodynamically significant, you're going to start to see some changes in your vertebral artery. So if you have what they call a latent steal, it means that the flow in that vertebral artery is starting to show signs of reversal, but it's not completely retrograde or backwards. So here's kind of what my, here would be a very early subclavian steal. You see that the systolic upstroke kind of ends and starts again. It's not that consistent brisk upstroke. That would indicate that there's some sort of hesitancy in moving that flow forward because of the lack of blood supply in that area. After that, you'll start seeing it going forward and backward. That's meaning the pressure pushing that blood up the vertebral is getting less and less because the occlusion is getting worse and worse. We call that a latent steal. It's got this hesitant big notch, but not enough pressure to move it forward, no pressure to move it forward in diastole, so it's got diastolic reversal. And you can even see it becoming more and more diastolic reversal, indicating it's getting more significant, and that's what we call a latent steal. Now, a complete steal is when we have the vessel and our flow is completely reversed and going to feed our arms. So that's a basic of our subclavian steal. It's something to be very familiar with because we really want to look for that vertebral flow in the right direction to rule this out. So here it is with our retrograde flow demonstrated in the vertebral. That would mean it's a complete steal. Okay, stenosis or occlusion, like I said, stenosis or occlusion are common in the ICA. Now, when we're taking our Dopplers and classifying stenotic changes, the only thing we really have a great chart for is our ICA measurements. So we're taking measurements in CCA, ICA, and ECA, but the only real ones that are going to matter when it comes to classification of stenosis are our ICA. Now, when we have stenosis or occlusion in our ICA, we can find some things in our waveform patterns that are going to be very alarming. So first of all, you'd see a decrease in diastolic flow or an increase in resistance. So here we know usually my ICA is going to look something like this. Here we've lost all end diastole, and we even have early diastole reversal, meaning as soon as that systolic upstroke is done, as soon as that heart starts to relax, our blood is actually being pushed backwards. So you're having like one step forward, one step back. That would indicate that it's a highly resistive bed it's feeding. Now, our tissues aren't getting that resistance, so it has to be coming from a stenosis. Overall, we can have what we call a very blunted appearing waveform. So this, again, is not going to happen overnight. It's going to gradually get a little bit more resistant, until the most resistant, which we would cause a monophasic, where it's basically pumping that blood, the blood's bashing into the stenosis, and it's being stopped, and you're only getting the tiniest forward motion when during systole. Now, it's always important, when we're doing carotids, we're always doing both sides so that we can compare these and demonstrate, if some of these changes could be due to a heart issue or different things, but usually stenotic changes are going to be up ahead or in the mid or distal ICA. The string sign is the sign that we see where we can barely detect any blood flow going through a stenosis. And again, that is so important to be able to get that string sign because it proves that there's still blood flow there and that the patient's a surgical candidate. Usually this is found in the ICA, and it's just what it says it is. It's just appearance of a string through the lumen because that lumen is so near occlusion. When we are looking or suspect a string sign, we want to image in both transverse and longitudinal plane. We want to lower our color scale as low as we can go and turn up our color gain as high as we can. We can then switch to power Doppler because it's not angle dependent and is a little bit more sensitive if we can't get it with our traditional Doppler. And we carefully evaluate distal for any flow we can get, because if there is flow distal, it means it's coming from somewhere, and there has to be some residual lumen there. ECA stenosis, these lesions tend to involve the proximal segments, and that's why that's the region that we are going to look at most closely. Now, these are associated with focal velocity increases, post-stenotic turbulence in a dampened distal waveform after the stenosis. You want to watch for diffuse increase in velocity or as a result of collateralization. So these vessels are pretty good at building collaterals, but when they do that, you will get that increase in velocity. CCA stenosis. You will see significant stenosis in the CCA. Lots of times these are going to reach the point of hemodynamic significance after the ICA already has. So focal velocities here are going to... Okay, and these significant lesions are associated with focal velocity increases, like we know when we have a stenosis, we're going to get velocity increases at the stenosis itself. It's going to be also follow the patterns that we're talked about, in that our resistance here in this proximal region is going to start elevating. Our velocities here at the lesion itself are going to increase, and then we're going to have post-stenotic turbulence here with a dampened waveform, because if there's hemodynamic significance to this, we're going to have less than the required blood flow, and so we'll see these tardus parvus dampened waveforms. You can also have a choke lesion, which can result in retrograde ECA to supply the ICA. So if for some reason the carotid is still able to provide the ECA flow, that flow can reverse out of the ECA and come back up the ICA and provide flow that way. And so that's kind of what you see happening here. The ICA is cut off, the ECA isn't. So when that blood gets into the ECA, it's kind of becoming turbulent, rotating back around and going in the ICA. So that's your choke lesion. Proximal system stenosis really refers to anything proximal to the carotid system. So this would be something that is really at the aortic valve or the root. So there could be significant stenosis at the aortic valve or the root, which would mean there's a decrease in blood volume that's getting to the carotids. So in this case, it would have that kind of post-stenotic appearance. You might see something that looks like this, kind of a tardus parvus, dampened waveform, spectral broadening. That wouldn't be uncommon. Now, if it's at the aortic arch, or if it's at the proximal aorta before any of the cranial branches, or if it's at the aortic stenosis, it's going to affect both sides bilaterally equally. So here you see the left and the right are both being affected, and that's because that lesion is prior to any of those vessels branching off, so they're going to affect all of the vessels. This can also cause bilateral low brachial systolic pressures. Now, if I have just one, blood pressure is what we're referring to here. If I have just one brachial pressure that's low and the other is normal, that could indicate that actually there is a lesion, but that lesion would be more towards the subclavian than in the heart itself. The brachiocephalic stenosis can affect only the right carotid system, whereas those are aortic stenosis, depending on where it's out, would affect both. So proximal system pathologies that we're going to look at now, first of all, low cardiac output. If our heart is not functioning well, it's not creating cardiac output enough to provide the expected pressures in the carotids. And so that would result in something like a post-stenotic appearance of some of our vessels. So we'd have kind of that tardus parvus flow, dampened forward flow, very low resistance, but that'd be because we have low blood. We don't have enough, or we don't have the expected amount of blood in that area. Aortic valvular disease can cause this, same type of appearance. Hypertrophic obstructive cardiomyopathy, again, that limits the ejection fraction, and it can affect how much blood is pushed into the carotid system. Cardiac arrhythmias, When you see these, the heart's beating irregularly, and so you never want to take your systolic and diastolic measurements on the first beat after an arrhythmic event. So this little waveform here, I would not measure that. I always want to try and get nothing before the third beat. So here you see they're accurately measuring on the third beat here. But these can be very challenging because with the arrhythmia, you'll see these unusual changes. Finally, we have cardiac assisted devices, which is actually helping the ventricle make its systolic contraction, I guess. These can be intra-aortic balloon pumps, and this is totally going to skew the waveform. So again, these waveforms, these measurements are going to be of limited use. So here we see a carotid artery Doppler waveform with an intra-aortic balloon pump, and you see it's very unusual, and it's really not going to be able to fit into our stenotic criteria that we utilize. Stenosis classification, so I've talked a lot about this, but what is it? So stenosis classification is the primary criteria for classifying stenosis severity. So number one, if we didn't use good Doppler techniques, our velocities are not accurate, and it doesn't matter where it falls on this criteria, it's still not going to be accurate. So we've got to make sure that always we're using appropriate Doppler angles, appropriate placement, appropriate scales, and getting the best reading or the best velocities that we can. We know that we have to do this sometimes by beam steering, sometimes by heeling towing our transducer. We know that we're only going to get the maximum velocities, especially in our stenotic areas, when we sweep through the stenosis and make sure that we obtain the maximum velocity. And we know that those velocities may be affected by collateralization, which could indicate that there's no issues where there really is a significant stenosis. The types of collateralization that can occur means collateral or building up alternative vessels around a stenotic area. It can be posterior to anterior, meaning that if I have a vessel, it's stenotic or occluded here, then a collateral can grow out, around, and back in. That would be posterior to anterior. It could be side to side going to another vessel. It could be extracranial to intracranial going from the ECA to the ICAs, and it can result in increased velocities contralaterally to the severe stenosis or occlusion. More so though, we usually have pretty good values to base our classifications off of. Remember that the classifications of stenosis off of this chart here is only accurate for the ICA. CCA and ECA cannot be evaluated with this chart. But if I have an ICA stenosis and it has a peak systolic velocity of less than 125 centimeters per second, but there's visible plaque or intimal thickening, we would know that our end diastolic velocity is less than 40, we could classify it as a 50% stenosis. If it was above 50, we would see that our ICA PSV is 25 to 230 centimeters per second, but there's visible plaque, and our ICA to CCA ratio is 2 to 4 with our end diastolic velocity of 40 to 100. We would put that in the 50 to 69 category. And we're just putting it in the category. We're not saying, oh, it's 55, it's 57. We're saying it's somewhere in here. Once you get up to greater than 70 all the way to 99, you can see a near occlusion. Your PSV is greater than 230 centimeters per second, and your ICA and CCA ratio is 4.0 with an EDV of more than 100 centimeters per second. That would tell you you're 70 to 99%. If you can't get any velocities, but you are able to demonstrate a string sign, you can call this a pre-occlusive or near-occlusive lesion. And if you have no detectable flow, then it would be a complete occlusion. Now, what makes this easy, if you have these values on that same tech worksheet that I mentioned that you could put your history and everything else on, it makes this process of evaluating for classification of stenosis much easier. So that's highly recommended that you put together really good worksheet that will make your job and your life much easier. Okay, now an additional classification set was created by the North American Symptomatic Carotid Endarterectomy Trial, and they have very similar but slightly different classification system. So you'd have to pick one or the other that you wanted to go with. But this one really just looks at those higher levels of stenosis. So if you're over 70% stenosis according to this criteria, you'd have a PSV of greater than 230 with an ICA-CCA ratio of 4.0. And your highest PSV is at the stenotic ICA. Now, this is not valid if there's any other significant CCA disease, such as atherosclerosis, and so this wouldn't be able to be applied in some of those patients. CCA stenosis classification, like I said, it does not go off of those charts, but there is some way we can begin to document it. So if we find a focal velocity increase with post-stenotic turbulence and distal waveform changes, we can say that it is a hemodynamically significant stenosis. If we see these three things, we can say we know it's at least 50% stenosed. Anything less than 50% will not result in the turbulence, the velocity, or the waveform changes. If we see 230 centimeters per second in our peak systolic in our CCA or ECA, usually that would indicate 50 to 99% stenosis. If we could still see a string sign, then we know that it's not totally occluded. Well, that was a ton of information for one lecture, but I hope you found something that you'll be able to use out of it. If you have any questions or if I can help in any way, please let me know, and we'll see you next week.